Okay, we have concluded our last conversation with spermatogenesis, and I just want to remind you briefly. So we've got spermatogonia, which are diploid, right? They divide, forming two still diploid cells. Okay, and then this diploid spermatogonia enters meiosis. And so original spermatogonia produces two daughter cells that is still diploid, and this daughter cells then, well, type B daughter cell that enters meiosis, and the result of meiosis from one diploid cell, you have 4 haploid cells. Does that make sense? And we also mentioned that sustenticides or Sertoli cells can be found inside of seminiferous tubules here. They facilitate maturation of sperm cells by guiding them through and nourishing them and preventing them from getting in contact with the blood. Now, kind of as a segue, the spermatogenesis is impossible without a hormone called testosterone, which is produced by Leydig cells, also called interstitial cells. So they produce testosterone that acts on the spermatogonia and Sertoli cells in the seminiferous tubules, facilitating spermatogenesis. Which brings us to the hypothalamus, pituitary, gonadal, or HPG axis. Brings us to the beginning of the semesters, the endocrine system. So hypothalamus right here produces gonadotropin releasing hormone. It enters the primary plexus, delivered by the hypothalamus-hypophyseal portal system to the anterior pituitary, where GnRH stimulates release of 2 gonadotropins, follicle-stimulating hormone and luteinizing hormone. Each of these hormones have their own target. Follicle-stimulating hormone interacts with the receptors on the Sertoli cells, on the sustenticides, and leads to the synthesis of androgen-binding protein. Luteinizing hormone interacts with the receptors on Leydig cells and leads to the production of testosterone. Before we actually discuss any effects of testosterone on the human body, just want to mention, look at this now, testosterone that is produced by Leydig cells, it actually binds to the androgen binding protein, and this binding, does that make sense? Testosterone is androgen. Are we clear? So androgen binding protein pulls testosterone in, increases testosterone concentration here in the seminiferous tubules, and testosterone then stimulates spermatogenesis. Does that make sense? So we've got GnRH, gonadotropins, testosterone. In this axis, what do we need to add? As in any endocrine axis. What do we need to add? Some feedback mechanism. What kind of feedback? Negative, yeah, inhibiting feedback, right? So we need to add negative feedback. Negative feedback is facilitated by two hormones. Testosterone, okay, which inhibits both gonadotropin-releasing hormone and gonadotropins, and another hormone that we mentioned briefly before, hormone called inhibin. Inhibin right here is elevated when the sperm count increases. Does that make sense? The number of sperm cells goes up, and you can imagine that testis and epididymis, they cannot store unlimited number of sperm cells. More sperm cells there are, the more inhibin will be produced. The more efficient inhibition of gonadotropin releasing hormone and gonadotropins will be. Does that make sense? So after ejaculation, when sperm cells are released and the numbers drops, right? Inhibin levels drop as well, because that's what regulates the inhibin levels. And gonadotropin releasing hormone goes up again, stimulates gonadotropins, they stimulate testosterone, testosterone stimulates sperm synthesis, and it all goes again and again and again. Does it make sense? We're clear? We're good? In males, levels of testosterone, when they start to elevate in childhood, and then they basically stable through life. When they start to decline, sperm levels decrease. That's why, usually they decline with age. That's why elderly lose fertility, okay? But since there is no precipitous drop like in females, like with menopause, in some males, steady levels of testosterone can persist till day 70 or 80, making them fertile even at that age. Does that make sense? When gonadotropin releasing hormone and gonadotropins are not produced due to some pituitary problems or hypothalamic pathologies, there's no testosterone. Without testosterone, testes, they shrink, they essentially atrophy. Does that make sense? Now, quick plug for, have you seen recently, well, it's not recently, but about a year or two ago, all TV channels were flooded with the ads on the testosterone replacement therapy. You may have seen that. Recommended for males in the 50s to increase declining levels of testosterone. And quite recently I stopped seeing those ads. Either TV knows that I'm not of the proper age yet, or already, I don't know, or they just stopped them, and I'm leaning towards the second. Reason for it, there were several huge studies on the benefits of testosterone replacement therapy. The answer is very brief. There are none. So there are no significant benefits in terms of fertility, in terms of bone density, in terms of muscle mass, and even in terms of such evasive concept as feeling well. Okay? It was placebo-controlled, double-blinded studies, and they found no benefit from prescribing testosterone replacement therapy. The additional problem with that, it used to be done in the fashion, imagine I come to my dog, Doc, I want some testosterone. He says, sure, seriously, sure, writes the prescription, and off I go. Some physicians never evaluated patients for prostate hyperplasia or prostatitis or even prostate cancer. Male, and so basically testosterone stimulates prostate cancer development. And people with prostate cancer They were receiving testosterone just because they asked for it. So they basically now reevaluating whether we should do that. So this shows you the testosterone levels through life. Of course, it's like not up to scale. But you see it decreases dramatically in puberty and stays fairly even through the adulthood. Testosterone is the fat-soluble hormone derived from cholesterol, produced, as we just discussed, in testes. Some of it is produced in the adrenal glands. Remember, we talked about zona reticularis that produces androgens in the adrenal glands. That's that. The levels of testosterone produced by adrenal glands are very low. So they're not sufficient to maintain the fertility function. Now, it's anabolic hormone that increases BMI. I'm not talking about performance enhancement. There are a lot of complicated biochemistry in this. Basically, pure testosterone leads to several effects. First, it decreases the production of endogenous testosterone, meaning if you take shots of testosterone, your own will start to cease, okay, which actually will reduce the size of testes and will reduce fertility. It will also be converted in the liver into estrogen, so long-term injections of testosterone will lead to the development of female sex characteristics. One of the common side effects of uncontrolled testosterone abuse is gynecomastia. And it actually damages the liver. Okay. In males, external genitalia, hair, like chest hair, pubic hair, skin thickening, skin becomes more oily, it controls libido, necessary for sexual function, including ejaculation and erection, formation of semen. All those sex-related things are under testosterone control. Also, testosterone stimulates bone growth and muscle growth. So when kids have that puberty growth spurt, that can be entirely attributed to testosterone. It also affects vocal cords by roughening basically vocal cords and deepening the voice. If you've heard the stories about kids with like angel voices, especially in Arabian countries, they were castrated. Their testes were removed, so they had no source of testosterone, and their vocal cords remained always, you know, that pre-puberty stage. So they had those very high-pitched voices. Does that make sense? Now, in females, first of all, I find female reproductive physiology much more elegant than male, because male is fairly straightforward. I mean, what can be more straightforward than this? Seriously, just from regulation standpoint, it's simple and straightforward. Female hormonal endocrine regulation is elegant. That's really elegant. It's so well fine-tuned. I'm amazed every time I look at it. So anatomically, vagina, which is stretchable tube, uterus, basically thick-walled muscular sac, and uterus is connected to ovaries by the fallopian tubes. A whole bunch of ligaments. Did I post the anatomy study guide? I don't remember anything. No. I did not? Oh, holy crap. Did I post? I didn't post reproductive. Kick me in the butt before the break. I'll post the anatomy study guides like open in my computer. I have it written. I just need to post it. It's like 1 page. There's not a lot. Huh? The anatomy list. Oh, okay. Okay, anatomy list. Pictures almost done. I just need to add what you labeling. It's like, it's done with the pictures. I just need to add like to label things. Okay? It's practically there. Huh? Yeah, so reproductive isn't there yet. I know that. It's going to be there. No worries. Now, for, so anatomically, a bunch of ligaments that hold basically uterus in place. Vagina and uterus are posterior to the urinary bladder and anterior to the rectum, and that explains the urge that pregnant women often experience, the urge to urinate, because enlarged uterus with the fetus inside it presses on the urinary bladder, forcing the urine out. That makes sense? Now, this is the anterior view of the female reproductive organs. So again, vagina basically ascends into the uterus. Uterus has few distinct parts. So this is the cervix of the uterus. Cervical canal in the middle that opens into vagina via external os and opens into the lumen via the internal os. Now uterus culminates here in the fundus of uterus, and then it is connected to the ovaries by fallopian tubes. Fallopian tubes, they deliver secondary oocyte that is released during the process of ovulation from ovaries, and it goes through the fallopian tubes. Somewhere in the fallopian tubes it encounters sperm if there is fertilization and ends up in the uterus. Basically, oocyte, whether it's unfertilized oocyte or fertilized ovum, they all end up in the uterus. If it's fertilized ovum, it implants in the wall of the uterus and embryonic development ensues. If it's unfertilized oocyte, it goes out with menses. Does that make sense? You see there are a lot of ligaments that hold it all together, so-called broad ligament. Consists of several parts, and you can actually see how name associates with what the part holds, like mesosalpinx. It holds ovarian tubes or fallopian tubes. Mesovarium, ovaries. Mesometrium, uterus. Okay? The salpinx, that salpin, it refers to the fallopian tubes. So ovaries are parenchymal organs. So parenchymal, I want to remind you, parenchymal organs versus hollow organs. So uterus is the hollow organ. It has a lumen, right? Like stomach, like intestine, it's a hollow organ. Parenchymal organ is the one that does not have a cavity. Say spleen, liver, ovary, thymus are parenchymatous or parenchymal organs. Does that make sense? You see the difference? There's many other parenchymal organs. Ovary has a cortex, outer cortex, and inner medulla. Cortex is loosely the layer in which gametes, in this case oocytes, are formed. And medulla contains blood vessels and nerves, blood vessels that deliver nutrients and oxygen to the tissue where growing gametes are. That makes sense? So here you can see different types of follicles, from very small primary to bigger secondary to large vesicular or antral follicle, which is ready to ovulate basically. In each follicle, oocyte is surrounded by the layers of granulose and follicle cells that regulate follicular maturation. One important thing that you have to understand about ovaries and fallopian tubes. Ovaries and fallopian tubes are not connected physically. There's space between them. Does that make sense? When ovulation happens and oocyte is released, you see there's a tiny little oocyte that's released here. It basically enters abdominal cavity. Does that make sense? And then it generally is taken into the infundibulum and then into the ampulla of the fallopian tube. What brings it in? This fimbriae. Fimbriae of fallopian tube, they move, and basically they do this. They, quote unquote, embrace the follicle and bring it in. And if it ends up in the fallopian tube, then it can be fertilized. Can it get lost in the abdominal cavity? Absolutely. Is it wrong? This is absolutely, well, I mean, by wrong, I mean, is it like something bad medically? No. Just, basically just goes away. Like lost. Like gone. Okay? Just destroy it. Nothing really happens there. Now, the issue of ectopic pregnancy. Remember, the term ectopic means in the wrong place. So ectopic pregnancy occurs when secondary oocyte is fertilized into ovum in the peritoneal cavity. That can happen, which is horrible. Or fertilization occurs where it's supposed to be, okay, in the uterine tube, in the fallopian tube, but the fertilized ovum doesn't make its way to the uterus, okay? So it remains into the fallopian tube and starts to develop in the fallopian tube. What can cause ectopic pregnancy? What is the most main risk factor for ectopic pregnancy? Think about this. The main point for, so what is the final destination for oocyte? So again, uterus. Now, ectopic pregnancy happens when oocyte cannot get to the uterus. What's between, what allows oocyte to get to the uterus? Which anatomical structure? Fallopian tube, which means there's something wrong with the tube, that oocyte cannot make it. And that's urinary tract, no, not urinary, sorry, sexually transmitted diseases. There's some kind of infection that happens in the fallopian tubes. It can cause a condition that is called Spermatogenesis. That fancy word means inflammation of the fallopian tube. Inflammation of the fallopian tube leads to the formation of scar tissue. And scar tissue may either decrease the lumen of fallopian tube or, most likely, destroy the epithelium. And now, put yourself in the position of the oocyte. You are in the tube and you need to make it to the uterus. Do you have any devices to swim, to move? No. So you rely on the tube to move you towards the uterus. Which extracellular appendages will propel you? Cilia. The ciliated epithelium. And if there are no functional epithelium, there are no cilia. If there are no cilia, there is no movement. So oocyte gets stuck in the fallopian tube, or not even making it into the fallopian tube. Now, ectopic pregnancy is usually aborted by itself. But if it's not aborted, then it's a life-threatening condition. Another problem associated with sexually transmitted disease is so-called PID, or pelvic inflammatory disease. It's basically when sexually transmitted disease goes undiagnosed for an extended period of time. It spreads from, so it starts with vaginitis, then eventually it infects cervix, cervicitis, then it'll infect epithelium of endometrium, the epithelium in the uterus, endometriosis, fallopian tubes, salpingitis, and finally, we'll get from the fallopian tubes in the peritoneal cavity. And that's pelvic inflammatory disease. At this point, it probably means infertility, because all those parts of the reproductive tract are severely affected. And main causes get two most common sexually transmitted disease, chlamydia and gonorrhea, and those are Trichomonas vaginalis, trichomoniasis to a less extent. It can be, but those two bacterial ones are the most frequent. Now, uterus. That's where implantation happens, right? So uterus consists of 3 layers. Perimetrium, which is serous membrane. Basically, it's the connective tissue on the outside of the uterus covered with simple squamous epithelium, which produces that serous, nothing interesting. Typical serous membrane. Does that make sense? And then we have super thick myometrium. Smooth muscle. Why smooth muscle in the uterus? To do what? Yes. Why? I'm playing dumb, so go ahead. Or what? Baby, yeah. To expel baby or expel the egg, yes. Or actually expel menses. Expel whatever. And think about this, you know, baby's usually of a considerable size. So to expel that kind of a creature, you need a powerful contraction. Pregnancy is the classical example of parasitic relationships. Baby is a parasite by biological definition. It is. So, and then you have endometrial layer. And endometrium is brilliant. It has 2 layers. Stratum functionalis and stratum basalis. So on the left you can see the what's the word? The micrograph. On the right, it's a schematic rendition. Now look at this. Blood vessels, like this arcuate artery, branch into the radial arteries, which then develop into like straight coiled arteries. Basically what happens, stratum basalis contains all those blood vessels, straight and spiral arteries that branch into the sinusoids in the stratum functionalis. Does that make sense? Every time a woman experiences menses, stratum functionalis is shed. Okay? The whole layer of endometrium is dying. It is released, it is basically washed away with blood, and then it grows back. Does that make sense? And I'm kind of getting you to the hormone regulation because it is super exciting. Like, really super exciting. So, anatomical parts of vagina. So, vagina consists of 3 layers. Adventitia, which is connective tissue, right? So, if we go back to this one, this on the outside, the thin white layer is adventitia. Smooth muscle. Vaginal contractions are necessary to actually, especially in reverse peristalsis, to propel sperm after the intercourse into the uterus so it can actually reach fallopian tubes. And mucosa, which is stratified squamous epithelium. Does it make sense to you that it's stratified squamous? Because of all the abrasion forces. Does that make sense? Now that mucosal layer forms hymen. So you can see ruptured hymen right here. Hymen is usually incomplete. Okay, it partitions, it separates vagina from basically the outside, usually broken after the first intercourse. The fatty area over the pubic regions of the coxal bones is called mons pubis. The skin folds surrounding vaginal orifice are called labia majora, and it's interesting because labia majora, if you would look at the development of reproductive organs in females, labia majora is scrotum. Does that make sense? It's male scrotum. It's just it was like before. It's the same structure that male scrotum is developed from. Okay. Now labia minora, the skin folds inside of the labia majora. You can see them right here. And now these glands called greater vestibular glands, they are the analogs of male bulbourethral glands. They produce mucus that lubricates vagina during the sexual intercourse. Clitoris, which is shown here, and it is covered by the prepuce, is essentially developmentally is the same structure as penis. So when development takes goes on that fork, whether it's a boy or a girl, if it's a boy, it's going to be penis. If it's a girl, the same structure will develop into clitoris. And this part is called glans of clitoris. Like there is same way there's glans penis in males. Does that make sense? Now, unlike males, females can produce milk. Can males produce milk? In gynecomastia, they can. If estrogen kicks up, there were recorded cases. I mean, of course, it's not sufficient to feed the baby, but there can be milk produced. But it's like really far-going estrogen increase in males. Does that make sense? So, mammary glands are sweat glands, basically. They changed, and they produce milk instead of sweat. The concept is the same. Fluid is taken from the blood, and then there are proteins and carbohydrates that go into the milk. Okay? So milk is collected into the lactiferous ducts, then go through the sinuses, and is released via the openings in the nipple. Now, breast size depends on the deposits of fats. It is known that women who gain weight, their breast size increases. Women that lose weight, their breast size decreases. It's largely determined genetically. In the US, second most common cause of death and cause of cancer. No, not cause of death, cause of cancer in females after the lung cancer. There are 4 stages. First and second are very treatable. Third is less treatable. Fourth is metastatic breast cancer. As any metastatic form, it's incredibly hard to treat. There are multiple risk factors. The problem with breast cancer, and did I talk about the book The Emperor of All Melodies? Read it. Basically, the whole book, it's about mainly about 3 cancers: breast cancer, lung cancer, and different types of blood malignancies. What was the treatment for breast cancer for the longest period of time? Mastectomy. And there was a surgeon, I think he was American, his last name was Halsted, who proposed radical mastectomy, with removal not only the breast tissue, but a lot of underlying tissue. Essentially, it was a disfiguring surgery. The problem with radical mastectomy often was not better than not radical, because often radical mastectomy failed to remove actual cancer cells, and cancer returned. Okay. Risk factors mainly are associated with different sort of changes in the female reproduction functions. Early menstruation, late menopause, no pregnancies or late pregnancies, therefore no breastfeeding, short family history, genetics. We have to bring celebrities here. Angelina Jolie, and she wasn't diagnosed with the breast cancer. She was diagnosed with the mutations in BRCA1 and 2 proteins. And these mutations are highly correlating with the breast cancer. And she got her breasts and her ovaries removed because this mutation is associated with ovarian cancer as well. There are multiple types of breast cancer. Breast cancer that is mediated by estrogen receptors. Breast cancer that is not mediated by estrogen receptors. And all those different types warrant different types of treatments. The most sobering thing probably, I speak about it with such passion because one of our family friends quite recently was diagnosed with breast cancer, went through the whole treatment, and is in remission now. And it was a grueling experience. I cannot imagine what it was for her and for her husband, but it was very life-changing experience for all their friends, including us. And I can tell you probably the first words of every person who, is diagnosed with cancer: why me? And it's most important to tell them there's no why. It's not, there's no guilt. You didn't do anything. Maybe you did, but don't think that you did anything wrong. And she didn't. She's one of the healthiest people I know. She leads like healthy lifestyle, not like obsessed, super like insane, but I mean, I compare to her, I put myself in the grave compared to her with my lifestyle. Okay? But nevertheless, she successfully went through the treatment. early diagnosis is the key. Palpations to determine lumps. It's not a paranoia to go to the doctor and bother them. Doc, I have a lump. Can you check? Mammograms help. However, recent studies showed that routine mammograms, basically every 6 months going through the mammogram, is so that approach doesn't decrease the risk for breast cancer. So a lot of it is just self-diagnosis, being proactive. So yeah, first and second stage would probably be treatable. I always say, it's good that we live in Cleveland. With Cleveland Clinic at UH, for any type of disease, we're lucky. Anyway, oogenesis, development of oocytes. It's kind of similar to the spermatogenesis. We start with oogonium. Remember spermatogonium for sperm cell? So that's basically the same. So oogonium is diploid. And this diploid cell divides, producing another diploid oogonia, and one of those two, after mitosis, turns into the primary oocyte. The primary oocyte, which is formed during the embryonic development and early childhood, they are arrested in the prophase of meiosis, prophase 1, which means they do not develop further. There's a certain number of primary oocytes that women have. However, so there was for a long time an idea that total supply of primary oocytes is determined at birth. Now more and more there's evidence maybe there are stem cells that during the adult life they give rise to new oocytes. Does that make sense? So this diploid cell, when we enter puberty, when females enter puberty, levels of estrogen start to rise, and that stimulates monthly development of oocytes into eventually secondary oocytes. So primary oocyte enters meiosis 1, and eventually after meiosis 1 completion produces secondary oocyte and a first polar body. What is the first polar body? It's dysfunctional cell, which is sort of an offshoot of the meiosis. Does that make sense? So it's not fertile. Secondary oocyte is fertile. Secondary oocyte eventually, when it develops. So imagine there's monthly cycle. Secondary oocyte develops by completing meiosis 1 and entering meiosis 2. When it enters meiosis 2, it stops at the metaphase 2. If you want, we can put down all the stages of meiosis, but I don't think you want to, and I'm not going to ask them. So don't worry about it. The point is, it's arrested. In metaphase 2, it's still secondary oocyte, and it is released during ovulation into the fallopian tube. If there is no sperm to encounter, what's going to happen to oocyte? It's going to be released with menses. But if it is fertilized by the sperm cell, it will undergo division again. Does that make sense? Forming functional ovum and another polar body. So I want to highlight a few key steps here. First of all, we start with one diploid oogonium right here. Does that make sense? That one diploid oogonium produces one diploid primary oocyte. This happens before birth and a little bit into the childhood. So far, do follow me. Every month during the ovarian cycle, primary oocyte completes meiosis 1 and turns into the secondary oocyte. It doesn't turn into the egg. It's not an egg yet. It's not ovum. Does that make sense? Only if secondary oocyte encounters sperm, it will complete meiosis 2, will become egg, okay? And then, you know, you have all this separation, the joining of the genomes and nucleus formation and so on and so forth. Does that make sense? Without fertilization, secondary oocyte never becomes an egg. Are we clear? How many, let's say fertilization happens, everything's good. How many eggs or how many ova one oogonium here produces? How many ova one oogonium produces? One oogonium, how many ova? One. That makes sense. And it happens once a month. So a woman produces, on average, I mean, I'm not talking about twins, but one ova, one secondary oocyte, okay, one secondary oocyte a month, which is haploid. Men produce sperm all the time. Counts are in millions. What's the difference? Why? What is the evolutionary reason why males can produce millions of sperm cells while females produce one? Yes. Well, biologically we probably can. So I don't think like there's any specific intrinsic cellular mechanism that would prevent oocyte from dividing like sperm cell. But it wouldn't be a viable option because there is not enough resources in a female body to maintain the development of 1 million babies, right? So that's the point. What's the function of the sperm cell? Deliver DNA, exactly. Just deliver. It doesn't. So there is no, males do not require to support physiologically with body resources to support the development of an ovum. So therefore, you know, that's all those sperm cells have to do. They have mitochondria. Do you know what they have mitochondria for? The sperm cells? Swim, yeah, to swim. That's it, to swim. They're great swimmers, like Michael Phelps's, little Michael Phelps's. But then only one Michael Phelps will get to the finish line. Okay? If there, and actually it's fascinating, if there are two, ovum becomes, it's dysfunctional. There are rare cases when oocyte can be fertilized by 2 sperm cells, but it immediately kills it. Okay? Does that make sense? So, if you look at the whole picture, you will still see that one diploid cell eventually produces 4 haploid cells. But 3 of those haploid cells, polar bodies, they will degenerate. They'll be gone. Because female body doesn't have resources to maintain so many ovum if they get all fertilized. Because if you think about the number of sperm cells that are released with each ejaculation, we're talking about 3 to 5 million cells. Just give them oocytes, they will fertilize anything. Even if only, I don't know, fractions of a percent will make their way through the fallopian tubes. They will fertilize still like hundreds potentially, but there are no hundreds of secondary oocytes. Does that make sense? Now this brings us to the ovarian cycle, and my focus here will be on the hormonal changes during the ovarian cycle. We're going to briefly talk about the development of the follicle, and then we're going to take a break, review the quiz, and come back and chat about hormonal changes. So, ovarian cycle refers to the egg maturation, and it has 3 main stages. It says 2 consecutive phases, but I put ovulation in between. It's a follicular stage, which is associated with the development of a follicle, which starts with a really, really small primordial follicle. And as primordial follicle increases in size, you still have an oocyte somewhere in the center, okay? An oocyte is surrounded by antrum and theca folliculi, which is formed by thecal cell. Eventually you can see the oocyte surrounded by zona pellucida, by the antrum. So this vesicular follicle is ready to ovulate. All this stage is pretty tightly regulated. It's 14 days. And then after 14 days, ovulation occurs. Ovulation ova. Basically, it's a misnomer because what is ovulated isn't ovum yet. It's the oocyte. So during the ovulation, oocyte is released from the follicle. You can see it here. But interestingly enough, what's left of follicle, so-called corpus luteum, it doesn't degrade yet. It stays active for another about 14 days, okay, producing hormones necessary for the luteal phase of the cycle, okay. So generally we consider cycle to be 28 days, but it varies between women. Luteal cycle is pretty constant. Follicular may slightly vary and contribute to those differences in terms of the time. So far, that makes sense. So we have primordial follicle, and then it goes pretty straightforward to the primary, secondary, vesicular, and the main changes that are associated with that development are in the structures around the oocyte that actually control the follicular development and ovulation. So we're going to go and take a break, and when we come back we will discuss hormonal regulation of the ovarian cycle.